Introduce Dr. Khuroo from Srinagar. Dr. Khuroo made the first clinical description of deaths in pregnant women in hepatitis, in an outbreak, a big outbreak of hepatitis in Srinagar in the late 1970s, early 1980s. And I've never met Dr. Khuroo. It's a great pleasure. Thanks for coming all this way. And one of the things that struck me about your work is that you did all this by simple clinical observation. Fantastic work. And actually you created a lot of work for every person in this room. So thank you.
Good morning, everybody, and thank you, Mr. Chairperson. At the outset, I must take this opportunity to thank Dr. Hans and his team who have invited me to deliver this keynote address, which will address many issues right from the discovery of the disease to the place where we are now and how we can move forward to the ultimate control and cure of this human pathogen. I'll raise in my talk many unresolved issues related to this peculiar human pathogen. And at the end of the talk, and probably at the end of the day, if you are clear on all issues of hepatitis C, you've not done a good job. I think the job should be to raise and keep you asking unresolved questions. Now, hepatitis E is a major public health problem in developed countries. About 1/3 of the world population is estimated to have been infected with hepatitis E. And in India alone, there are about 2.2 million hepatitis E cases occurring annually. In 2005, there was an estimate that there are about 20 million incident infections in endemic areas with 3.4 million cases of hepatitis E, with 70,000 deaths and 3,000 stillbirths. What you see in the red flag, I believe that this probably is an underestimate. If you see the disease, global changing epidemiology and new data, probably the antibody dynamics and occurrence of reinfections. And because of these, I think these data need to be revised. So for all times, since I was with this disease, it was thought to be a disease of those third world countries, but no more. Hepatitis E is an important clinical problem in industrialized countries, as you see in this bar diagram. More and more cases are being described, and most of them are autochthonous and occurred indigenously. However, if you look at the zero incidence of hepatitis C infection in some of the countries, particularly Europe, and estimate the number of cases which should be there, I think this is what shows the bar diagram is a tip of the iceberg. Most of the infections must be either subclinical or not being diagnosed because you don't have a diagnostic kit available, or treated as drug-related liver disease and so on. So the story is to unfold. Hepatitis E was a remarkable human interest story with many complexities, missteps, near misses, ups and downs, as with many other events in history. The story is fascinating, as rightly stated by the chairperson, that it originated from one of the most remote regions of the world with very hard weather conditions and primitive health and investigative facilities. This story also focuses on the fact that discoveries do not necessarily need high-tech laboratories or institutions, but can be done in very primitive situations as well. An example as in focus. Now, discovery of hepatitis E, the 78 casual epidemic, had caused colossal human suffering and deaths. 52,000 cases with 1,700 deaths. And over the next 14 years, from 78 onwards, we presented the data of a disease which was enterically transmitted in the epidemic as well as in the endemic form. While for the last 4 years, hepatitis E story has progressed a lot. It's a matter of great concern that we're not been able to furnish answers for some of the very basic, unique features of the disease. Number one, why should repeated epidemics of hepatitis E occur in a periodic intervals in the same region over the years? Number two, why should the disease which is enterically transmitted occur in adults and severe children? Third, the peculiar phenomena of pregnancy and viral hepatitis, why should it happen with this pathogen? And last, in an endemic disease, what is the route of transmission, and so on. And there are so many unresolved issues. I think today, whole day, we're going to discuss some of them and see whether we have or we don't have answers. Hepatitis E is a 27 to 32 nanometer virus particle. It is spherical, and it is icosahedral in symmetry, has peculiar spikes on its surface. Virus is resistant to heating at 56 degrees for 1 hour. However, it is susceptible if you boil or fry items for 5 minutes, or the most important thing is if you chlorinate the water, the concentration and the viability of the virus goes significantly low, and that's very important for us when we're fighting the epidemics. The viral genome is a 7.2 kilobase RNA virus, single-stranded. It has a cap at 5'N and a polyadenated 3'N. The virus itself, replicant, gives rise to one genomic RNA, which is 7.2 kilobase, and a subgenomic RNA, which is 2.2 kilobase, which is bicistronic, gives rise to 2 operative frames. It has 3 operative frames, or 1, 2, and 3, which encodes 3 proteins, the ORF1 protein, 2, and 3, and the structure and functions of these proteins are going to be a discussion of today, and I'm sure particularly there's a lecture on ORF3 protein where Dr. Pada was going to raise several issues about the function of this important protein in hepatitis E. ORF3 has been expressed in baculovirus as well as in Escherichia coli, and gives rise to a number of either full-length protein or a truncated structures, and 3 of them, as seen, would give rise to virus-like particles. And these 3 virus-like particles, these 3 structural virus-like particles, have 2 important characteristics. One, their surface structure is like a native virus, so it's very important you can see these unique features of the structure of the virus. And second, it has an indigeneity, so that 2 of them, which are empty, are used for the 2 vaccines. And this is the Chinese vaccine which the chairperson talked of, P239, and this is the vaccine which was used in Nepal trial many years back, but has not been seen commercially. The proposed replication of the virus is shown from its attachment to its egress from the liver cells, hepatocytes. Number of steps in this whole structure are missing, and I think just because we don't have a proper in vitro culture system, so it's become difficult to really explain how this attachment and egress of the virus occurs. More known about it is better or will be for the knowledge of hepatitis E virus. While we're on that, hepatitis E has a remarkable heterogeneity with many groups, genotypes, and subtypes, but probably important that it has one serotype, Classification of this virus has been a huge hassle, as you see the number of classifications, and as of today, it's been classified into one group of all hepatitis E viruses have been classified into Hepatitis and 2 genuses, and the ortho-Hepatitis A includes the human hepatitis E viruses, the genotype 1 and 2, which only infect humans and probably have the reservoir inside humans, genotype 3 and 4, which infects humans and a number of animals, and is involved in the zoonotic transmission. And this is the disease which we will discuss probably more later. And the 2 isolates, which are in the wild boar from Japan, and this dromedary camel virus from Dubai is the genotype 7. The rabbit hepatitis E virus has been included in the genotype 3 as a distant member, and also there's a human isolate with that. So probably this classification would be important because the new viruses which are being sequenced can be easily introduced into this classification, and the confusion in the classification probably is going to be reduced. Leaving the virus, talking about the disease, the genotype distribution in the globally is very subtle. And because of that genotype distribution, you have 4 types of disease epidemiology and disease patterns seen in the world. Genotype 1 is a disease which mainly is in Indian subcontinent, Southeast Asia, probably part of Central Asia, many African countries, and some South American countries. And the disease it causes is either hyperendemic, where you get epidemics of disease, and in between the epidemics, the disease is endemic in those regions. Or it causes endemic disease, while you don't have epidemics, you have a disease with seasonal variation, particularly with the monsoons. Genotype 2 was described in Mexico and some of the West African countries, also causes hyperendemic or endemic disease. Genotype 3 is a disease which is present globally in swine and other related animals and is associated with zoonotic foodborne transmission to humans in industrialized countries. And genotype 4 is also prevalent in swine in many countries and also is associated with foodborne transmission, particularly in mainland China and Taiwan. In Japan, you have both genotype 3 and 4, and there are some genotype 4 also described some European countries. So one country which comes distinctly out of this is Egypt, while the epidemiology of hepatitis E is very distinct and doesn't look like hepatitis E epidemiology, it more looks like an hepatitis A epidemiology. So this would be so ladies and gentlemen, I just wanted to put you this slide which tells you about the significant morbidity and mortality of this pathogen in developing countries. In epidemic disease, there are large-scale waterborne epidemics which come at periodic intervals involving hundreds, thousands, and hundreds of thousands of cases with significant morbidity and mortality. Most of these epidemics in developing countries are not documented because of political reasons, or are not even studied at all because you don't have investigative facilities. Endemic disease, which occurs in hyperendemic region in the intra-epidemic period, or as a continuous disease in endemic zones, is very common, and estimated 2.2 million only in India per year, and constitutes about 2/3 of acute sporadic hepatitis in these countries. Acute liver failure also is very common in developing countries, although we don't have the estimates. and about half of them are related to hepatitis E. Then remarkably, hepatitis E infects pregnant women 8 times more than non-pregnant women and causes deaths 15 times more than non-pregnant women or controls. And if you look at these villages where you get epidemics, after the epidemics, you may not find a third trimester pregnant woman. This is the type of deaths it causes. Nearly about 50% of these women who are pregnant third trimester are wiped out. Hepatitis E also causes superinfection in cirrhotics. About 21% of the cirrhotics in India are infected with hepatitis E, presents as a rapidly progressive liver disease, and short-term mortality is as much as 34%. And to continue the woes of hepatitis E, we have issues of fetal and neonatal transmission, post-transmission hepatitis E, and extrahepatic manifestation of hepatitis E. And this puts most of the healthcare workers and many of the specialties so busy in our part of the world. How come hepatitis E gets such guts and courage to cause such a massive problem in our community? Waterborne fecal transmission occurs through a number of mechanisms, as are shown in these phase diagrams. But the most important is around 300 million Indians would defecate in the open, and about 60% of the world population without latrines occur in India. And to tell you another thing, that an average Indian, more Indians have a cell phone by their right ear to make a phone call than have a latrine to defecate. So this is a major human problem of sewage and sanitation, and that is what is hitting the developing countries to the extent of what I showed you in the previous slide. And Mr. Chairman, sir, to fight this human pathogen, the first thing is to have a safe potable water, and we can only have a safe potable water if we get a proper sewage disposal. And not only for controlling hepatitis E or other infection diseases, if you get a proper sewage disposal, it can improve upon the GDP of these countries. It can improve and give dignity to the woman and give them safety. You must have heard in the international press about safety of women, particularly related to open defecation, and also improve the school health, attendance and the health of the children. So it's very, very important. And this government, which has come up in India now, has committed about $10 billion to be spent over the next 5 years only for sewage disposal and school health and latrines. And it is expected that 1.2 billion people will get latrines for the next 5 years. However, I personally believe the issues are not going to be sorted out as quickly as you think. Also important is for control measures. It's shocking to understand that once you get an epidemic, you don't have even basic healthcare facilities available in these villages. There is no primary health at all. So even in the Kashmir epidemic, we had to really make a makeshift arrangement of healthcare to identify people with hepatitis, to really send them to higher centers if they have acute liver failure, and to treat them, and chlorinate water. What we're doing now about hepatitis E fighting is only a drop in the ocean. And I think much more needs to be done to fight this human pathogen. And the most important thing is what the chairman, to start with, said: the availability of a safe, effective, easily administered, and cost-effective vaccine. I personally feel the vaccine should be orally administered, like polio vaccine. And you can see how good the work has been on polio vaccine in India. And if we have an orally administered vaccine, it will be much better. But not having that, even the vaccine P239, Earlier it is with us, better it is. I'll take few of the contentious issues of hepatitis E to explain what's happening with the disease of unresolved issues. Repeated epidemics occur. Why should they occur? In the same region, if you get about everybody gets infected, then how come you can have another epidemic? Over the 30 years I've been working in Kashmir, we have seen these epidemics coming and going and looking at the antibody dynamics of the population and trying to understand what is happening to the antibody dynamics and to the occurrence of the epidemics. I must also tell you that while we are on that, the pressure of a fecally contaminated water is constant all the time. It's not that today you get a fecally contaminated water and have an epidemic, and tomorrow you get a clean water. There is no clean water. The force or the pressure of fecally contaminated water is constant here, and you get epidemics at particular times. And we made a hypothesis on this. We feel that the baseline prevalence of IgG antibody hepatitis C virus around 4%. It plateaus at 10% in higher age groups. And once you get an epidemic, and we have seen it that repeatedly, the whole population is seropositive around 20% in all age groups. And over the decades, this prevalence of antibody house becomes about 10%, and new group of cohort of population is not exposed to the virus in the inter-epidemic period. And this is the ideal setting for having a new epidemic. And every time, in every 20 years, once you get this phenomena, you get new epidemics in the same region. And I think this has to be tested in other regions, hyper-endemic regions, and see whether this stands, at least in Kashmir, this hypothesis stands in the repeat epidemics over 30 years. Ladies and gentlemen, we actually started with disease investigation. We wanted to find out what is the relationship of viral hepatitis and pregnancy in India. And this disease causes acute liver failure in pregnant women. It's rapidly progressive. You get high percentage of cell edema and you have sepsis. But the most important thing is that these ladies get a high percentage of disseminated intravascular coagulation. Why should the pregnant woman get so badly affected? Is there anything issue with the nutritional status? Is demographics, the virus status, and the clinical status of these women? And we're trying to find that there is nothing on this side that works. There are two factors which may work. Is one, I'm sure we'll listen about this, that there is a shift of T1 helper cells to T2 helper cells, which might give more cytokines. And also, the estrogens and progesterones might impair immunity to cause this problem. But because the immunological status and the way the liver injury occurs in hepatitis C is not well understood, I probably feel we'll have more time to understand this. But we've been giving a hypothesis that is hepatitis E in pregnancy a Merit syndrome? And we know there are several Merit syndromes in hepatology, that if you get vertically transmitted infection to the fetus and causes very severe liver disease in the fetus, can this fetal liver disease severe affect and overload the pregnant woman? And we have several data which have recently shown that this probably hypothesis may be true, at least in the setting we are in Kashmir. Other people have started, at least there's a publication from Bombay, which has also showed that this phenomena may be working in pregnancy with liver disease. One of the important issues is transfusion-associated hepatitis E a possibility, and what is the how much does it occur? We were first in 1995 to show that hepatitis E transfusion-associated occurs. We showed it in 13 patients out of 145 multiply transfused patients. And we traced 3 of these to 4 donors. And then this important paper from Japan came, where a case of transmitted hepatitis C infection was traced to a FFP from a donor with complete patient-donor sequence identity. And the last slide shows the most important. There are several case reports which have happened from 95 to 2014, and this paper from UK with Lancet last year showed that 18 of the 42 HEV positive transmitted recipients developed hepatitis C infection. And let's look at the HEV RNA in healthy donors. In India, it's very high, but it occurs all over in most of the countries, possibly not reported from US. And the recent, and you can see that how many transfusions you need to be given to carry one hepatitis E virus infection. And if you extrapolate this data, in England at least per year, there would be estimated 80,000 patients of hepatitis E which will be occurring per year. In this country where we are today, around 1,600 to 6,000 deaths occurring per year. And in some countries, a case is occurring practically every day. And very important is that those patients who are at high risk for developing either pulmonary hepatic failure or chronic liver disease are usually transfused. And so this will be a problem. And so there is an urgent need to consider, at least for Europe and Indian subcontinent, that donors should be tested for hepatitis C. One of the experts here in this hall, Dr. Kamal, shocked me when he said that chronic liver disease occurs with hepatitis E, because we had never seen chronic liver disease. And we know now hepatitis E genotype 3 causes chronic liver disease in a subset of patients with solid organ transplant and HIV patients and those who are immunosuppressed. And a large series has been studied in Europe and also some cases from other countries, but we have not seen this disease because we see only genotype 1 and it's not reported with genotype 4 also. And how does this disease occur in this? It occurs as zoonotic foodborne transmission. There's a cross-transfer between these three animals, and eating these animals raw or undercooked causes disease. Also, I went to the supermarket yesterday to look for this Caucasian Figetillo. I don't know whether I'm doing the correct spelling. This sausage, I couldn't find it, but that is the focus of attention, and also the raw liver, pork liver, which causes hepatitis E genotype 3. And obviously, to fight this disease in this, you probably need to tell your patients not to take pork liver and also not to take these sausages. And probably testing for transplant who are positive and treating them would be important, and the issue of this vaccine. Very important is treatment of chronic hepatitis E has been well studied in Germany, in France, and many other countries, in UK, where that's why the disease is more common. And algorithm for treatment is already available. Important is to say that some patients of hepatitis E genotype 3 may be getting resistant to ribavirin, and I think that's a matter of concern. Ladies and gentlemen, the diagnostics of hepatitis E has gone through a big problem, and you have issues of assay variability in performance, issues of genotype applicability, poor performance in immune disorders. However, IgM antibody in immunocompetent hosts probably is a good test to diagnose hepatitis E. But in immunocompromised hosts, you might have to look at the virus itself, because some of them will be negative. IgG antibodies also have a major problem. The seroprevalence that are probably needed to be redone because with these new antibodies available. It can also diagnose acute infection, and it's very important for national protection and protection with vaccine efficacy that we have a good test for IgG antibodies. HEV-RNA is a good test for acute infection. The only problem is that the viremia is short-lasting, but it should confirm chronicity, antiviral response, and donor screening. Already we will talk so much about this at the end of the session. The vaccine from China is available geographically. It's a breakthrough in this disease. I do appreciate the WHO paper just published some time back that we need to test this vaccine in a number of situations as I put here. But how do you test it? If you don't have the vaccine outside China, you just cannot test it. And I also will have to also test whether this vaccine will control the epidemics and also will control a more virulent disease of genotype 1 we see in India, and also the different disease of genotype 3 which you see here. But if you don't have the vaccine, then who is going to bell the cat? And I'm sure the chairperson has belled the cat by writing an appeal in Lancet of 21 signatories, and I told him I would have been the 22nd, to talk about a Nepalese 500 women who are at risk of dying because of earthquake. And I also promised to show him this picture of earthquake in Kashmir, which came in 2005, killed about 100,000 people. And you had a high incidence of hepatitis C following that earthquake. And as we are today here, we are facing already a flood in Kashmir. And we already have, from this August, we already have 6 outbreaks of hepatitis E, which are following floods. Hepatitis E is a disease which has major issues, and these major issues are listed in this. Slide. And these 4 major issues are issues of understanding the epidemiology of the disease, issues of understanding the issues of understanding the diagnostic issues of the disease and looking at the treatment of the virus and obviously the control. And ladies and gentlemen, it has been a pleasure to present before you a story and a tale of hepatitis E for the last 34 years. This started with my extreme belief that epidemics of jaundice and resultant mortality in pregnant women in our community had a hidden saga, and to uncover it needed hard work, persistence, belief in oneself, and honesty of purpose. It needed courage to stand on feet, to fight those skeptics, and also listen to the voice. And I've done that with persistence. It meant spending days in snow-bound rubbish roads, which I showed you in those villages, and feeling the pain and the anguish of those who suffered the disease. I needed nights to spend with pen and paper to write what I believed was true and to uncover it. While this journey was treacherous, was hard, was full of failures, and few successes, the end has been pleasant as today and rewarding, for discoveries do not come without price to be paid. And last of all, I leave before you a photograph of the world-famous tulip garden in Kashmir, while with one grandchild, 2 grandchildren, a son and a daughter, are enjoying the world-famous tulip garden. And I invite all of you to visit this famous place. Be my guest, and God bless you. Thank you.
We're not taking questions on this, so we're going to straight on to the next section.
Beer pipes. That's 7,000 pubs in Berlin, and all the construction workers have a deal with the breweries. You nearly believe me, huh? You nearly believe me. So that's all water, all groundwater. Groundwater.
I'm going up to teach them to do the Hepatitis.
You should don daryavan pet Berlin. Hey, what's the darya?
Yeah, it's just an amazing experience. What about you?
Better drinks here, I'm sure.